Hello friends, session number 8. Myself Dr. Amay Udyawar from Mumbai, India. I welcome you all to this interesting session. Moving away from didactic lectures, we have an interesting session which is an interactive quiz based format, and the topic is CIED, Deciphering ICD and CRT electrocardiograms, intracardiac electrocardiograms. So, the speakers for this session are going to be Dr. Paul Friedman, who is from Mayo Clinic, Rochester, USA. The second speaker is going to be Dr. Kartikeya Bhargav from Medanta Hospital, New Delhi. The third session will be by Dr. Neeraj Yadav from Ahmedabad. The fourth session by Dr. Kenneth Allen Bogan from Richmond, USA. And there'll be a wrap up by Dr. Vadivelu Ramalingam from Tamil Nadu. I'm sure all of these cases are going to be interesting and we are going to enjoy this session. Thank you.
So good afternoon, everybody. Good afternoon, Dr. Vadivelu. I will be talking to you in the next 20 minutes or so, discussing about a few interesting EGMs from ICD and CRTD devices. I'll start with my first case. Palpitations in a patient with dilated cardiomyopathy, left bundle branch block, and implanted with a CRT-D device. She complained with history of palpitations and multiple episodes were recorded, though she didn't receive any shock, but therapies were delivered. So this is one of those representative episodes where the device diagnosed it as VT. You can have a look at it carefully. The ventricular rate was about 179 beats per minute. The device delivered ATP therapy, which was successful. And you can look at the intracardiac EGMs in the right panel. The top panel shows the atrial sense amplitude. The uh, the second channel shows the V sense amplitude, and the third channel is the discrimination or the far field channel, followed by the marker channels and the marker intervals. So my first question is the device diagnosis of VT correct? I don't know whether polling will be working here or not. And the choices are yes, no, need more data, or can't say. Do we have polling here?
Just give us a minute, sir.
Okay.
Yes, it's on, sir.
All right. So let's give 5 or 6 seconds for the people to answer. A is yes, B is no, C need more data, and D is can't say. I'll go to the previous slide again so that people can have a better look at it. And do we have the answers now?
Sir, everyone is for can't need more data.
Okay. All right. So if I go back, if you look at this, the morphology is marked in the numbers. If you look at the morphology of the EGM, it's about 93% to 96%, 88 to 96%. So it's matching the template, and there is one-to-one AV relationship, and the tachycardia starts with a PAC. You can see a PAC here, which is marked as AR. It falls in the post-ventricular atrial refractory period and then initiates the tachycardia. So all this suggests that the diagnosis is not VT. And so the correct answer is actually no. Now, the following fact is true regarding the episode. So we have another 4 choices. One of the options is correct and others are false. Now, SVT, VT discriminators were not applied since the device diagnosed the tachycardia in V greater than A rate branch. B, VT diagnosis was based on sudden onset of the tachycardia. C, atrial undersensing due to abnormal atrial lead parameters is the likely cause of incorrect device diagnosis. And D, morphology criteria indicated VT in the episode. So let's have polling and then we can discuss.
So people have voted for VT diagnosis.
Okay, so VT diagnosis was based on sudden onset of the tachycardia is not the correct answer. The correct answer is the SVT VT discriminators were not applied since the device diagnosed the tachycardia in V greater than A rate branch. So if we go back, you look at this diagnosis summary, it says VT V more than A rate branch. Though typically it is 1-to-1 AV relationship, but if you look at the markers, the lower vertical bars suggest the ventricular sensing, whereas you don't have any vertical markers to suggest that atrial events were sensed. And the primary reason they were not sensed, but because they were all falling just after the sensed ventricular events and were falling in the post-ventricular atrial blanking period. And so the device did not detect any atrial events during the episode. And hence it fell into the V more than A rate branch, and hence no SVT discriminators were applied here. So if you look at this again, the same thing, it says VTV more than A rate branch, and the device then went on to deliver ATP therapy, where this is the ATP delivery, and you find that after that, during the after the ATP, the tachycardia terminated, and the during VVI pacing during the episode, you see only VS markers, and E, which is the end of the episode, which was previously called as return of sinus in the Abbott devices, happens, and then it is followed by a sync AV algorithm coming into picture, followed by biventricular pacing. So my next question is, which statement is true regarding the ATP therapy in this episode? A, ATP therapy was appropriate and successful. B, ATP therapy was inappropriate and unsuccessful. C, ATP therapy was appropriate but unsuccessful. And D, ATP therapy was inappropriate but successful. Let's see what the audience thinks about it.
Sir, it's 50-50 for ATP therapy was appropriate and ATP therapy was inappropriate.
Okay, so if you look at this, it was not a VT, and so the therapy was actually inappropriate, but it definitely terminated the tachycardia, and you can see that the termination happens somewhere here, and the next sinus beat comes here. So the tachycardia was a supraventricular tachycardia, but was terminated by ATP therapy. So this was an inappropriate therapy, but successful. So that can also happen. So if you go back to the Abbott discrimination or rate branch flow diagram in Abbott ICDs and CRTDs, the device looks at the ventricular detection rate and then compares the atrial and ventricular rates in patients who have dual chamber ICDs or CRTDs. And if it finds that the ventricular rate is higher than the atrial rate, it straight away diagnoses it to ventricular tachycardia and delivers the therapy, and does not apply the SVT, VT discriminators as in the present episode. Whereas if it is in the V is equal to A rate branch, it looks at the AV interval delta, and if find if the AV association is varying, it indicates that it is ventricular tachycardia and delivers therapy. If it finds that the AV relationship is intact, it then looks at other SVT discriminators like morphology and arrhythmia onset. And then one has the option of programming it. If any of these are true or all are true, then it delivers therapy. Similarly, in V less than A rate branch, the idea is to diagnose atrial flutter or fibrillation. It looks at the morphology match and the interval stability, as well as the AV association delta, and then delivers therapy if it thinks that it is VT, or withholds therapy if it thinks it is supraventricular tachycardia. So just to summarize this case, this was a tachycardia with a cycle length of 335 milliseconds in the ventricular tachycardia zone. The morphology discrimination suggested good match. and the sudden onset goes against the diagnosis of sinus tachycardia. But SVT, VT discriminators were not applied since the device diagnosed it in the V more than A rate branch. Since the atrial EGM is simultaneous with the V EGM, it fell in the post-ventricular atrial blanking, hence it is not counted in the atrial rate. Hence the tachycardia falls in the V more than A rate branch, and VT was diagnosed inappropriately. And ATP therapy, although inappropriate, successfully terminated the tachycardia. And the pattern of the episodes, initiation by a PAC and a good morphology match, all suggested a diagnosis of typical AVNRT that was confirmed on the EP study, and RF ablation of slow pathway was performed in this case. A word about post-ventricular atrial blanking. It's a parameter that establishes an atrial refractory period after a ventricular paced and sensed events to prevent the atrial channel from detecting the far field R waves. Atrial events falling within the PVAB period do not update the filtered atrial interval, are not used by the rate branch algorithm for dual chamber SVT discrimination mode, and are not counted in the ATAF diagnostics. So this is one of the where the device, the ICD devices may not be able to look at the atrial EGMs, and if all EGMs fall in this period, this becomes a problem. And the nominal values of PVAB are 60 milliseconds in the dual chamber ICDs and 70 milliseconds in CRTDs, but can be programmed anywhere from 30 milliseconds to 250 milliseconds in interval of 10 milliseconds. Now let's go to the another case, shock received in a patient, a 59-year-old lady who was implanted with a CRT-D device about 6 weeks ago. And this was the ECG during the episode where the patient delivered, the EGMs during the time the patient received a shock. So see them carefully. The top panel shows the A sense amplitude. The middle panel, next panel shows V sense amplitudes. Then a far field or a discrimination channel, the marker channels, and then the intervals. And the marker channel suggests some fibrillation beats, wind in the fibrillation intervals. This is again continuation of the same. Some beats, some intervals are not binned, and then some are binned in the fibrillation zone. And then the device diagnoses this as VF and then delivers a shock. Now, the true underlying rhythm during the detected episode is, and the choices are A, ventricular tachycardia, B, ventricular fibrillation, C, atrial fibrillation, and D, sinus rhythm. So can we have the answers now, please?
Sir, it's for D, sinus rhythm.
Great. So this was actually very simple. Looking at the EGMs looks very clearly sinus rhythm, but the device diagnosed it at VF. And the incorrect diagnosis of VF is due to, so we have the next question, double counting of the R waves, T wave oversensing of the atrial activity as R waves, and D, none of the above. So what does the audience think about the reason for incorrect diagnosis of is binned as a fibrillation wave? And as the number of fibrillation waves became the nominal 12, the device diagnosed this as VF and then delivers an ATP therapy. So here it is the ATP therapy. While the device is being charged, you can see the asterisk marks which indicate charging of the device, and the ATP therapy is then delivered. And after that, the device detects that the rhythm is back to sinus. So the correct fact regarding the delivered ATP is A, appropriate therapy, B, terminates the tachycardia successfully, C, induces true ventricular fibrillation, and D, shows intermittent loss of capture. So what does the audience vote for?
So it's D, shows intermittent loss.
Absolutely, that's wonderful. So you see that during the pacing spike, during the ATP, you find that the first and the fourth spike are not followed by uh, the electrogram in the discrimination channel indicating non-captured, and that very clearly suggests that the lead probably is not in its regular place. And then the device gives a shock again, because during the after the first shock it still find that there are VF intervals. And once the redetection criteria is met, which is again more stringent than the initial detection criteria number needed to detect, it gives another shock. And after that, the somehow the end of episode occurs. Now the way the device, the Abbott devices diagnose ventricular fibrillation and ventricular tachycardia is by looking at the current interval and the average interval. So the current interval is the interval where it is looking at uh, the RR interval in the current interval, and looks also at the average interval of this current interval plus the preceding three intervals. So for example, here the current interval is 500 and the average interval is sum of all these four intervals divided by 4, which is 469. And looking at this, then it bins each interval into either sinus zone, VT zone, or VF zone. If both current and average interval are the same, then it bins into the same zone. For example, if both are sinus, it bins into the sinus zone. If both are VT, it bins into the VT zone. And if both are VF, it bins into the VF zone. If the current interval is a faster in a tachycardia or a fibrillation zone, whereas the average interval is sinus zone, then the device does not bin that interval, and that is marked by a horizontal dash in the binning markers. On the other hand, if both current and the average interval show a tachycardia or fibrillation, then it bins the interval in the faster of the two zones. And so if one is VF and the other is VT, it bins into VF, and vice versa also, it again bins into VF. And in contrast to the Medtronic devices where they look at the consecutive counters, the Abbott devices look at the number of counters, and if it meets the number needed to detect, which is typically 12 in a VF zone and 16 in a VT zone, they are not consecutive, then it diagnoses this as VF or VT accordingly. So the last question for this episode is the most likely cause of inappropriate VF diagnosis is A, RV lead dislodgement into the tricuspid annulus, inadequate R wave amplitude, tip to coil or integrated bipolar sensing programmed, and D, ventricular bigeminy.
Sir, it's for option A.
Right. So this was quite easy, and this was the ECG during the fluoroscopy when the device lead was actually repositioned or reimplanted, and you can clearly see that the device, the ICD lead, has come into the annulus and is lying and detecting the atrial events as well. Now, the episodes here was detected in the VF zone, and hence algorithm which is known as bigeminal avoidance is not applied, which is applicable in the VT zone, which looks at these kind of intervals where one is sinus or not bin and the other is a tachycardia interval, and then avoids therapy by this algorithm called bigeminal avoidance. However, if these events are in the fibrillation zone, this algorithm does not work. So my last case, I'll go through it quickly. An episode of a shock in a patient with dual chamber ICD programmed in 3 zones. While the patient had an argument, this episode was recorded and diagnosed as VT. The VT rate was kept at 150 beats per minute, and the tachycardia occurred at 153 beats per minute or 390 milliseconds. And you can see the upper is the A sense channel, V sense channel, and then the marker channel. You can see that there is a morphology match, which is indicated by a check mark below the tachycardia annotation. And then the questions, the first one, the least likely diagnosis of this episode is A. Sinus tachycardia, B. Atrial tachycardia, C. AVNRT, and D. Ventricular tachycardia. For the sake of time, I'll tell that the answer is actually VT, because you see that it is a 1-to-1 tachycardia and the morphology is matching with the template, so very unlikely to be VT. And if I show the sinus rhythm template, that this is during sinus rhythm, you see that during a cycle length of 824 milliseconds, the AV interval is actually 406 milliseconds. That is, patient had a marked first degree AV block with right bundle branch block. You can imagine that at a rate of 150 beats per minute, he can very well have the AV interval of about, say, around 400 milliseconds, so that both A and V episodes look nearly close to each other. So the most likely diagnosis, once we know that the during sinus rhythm patient had a marked first degree AV block, is sinus tachycardia, and this is also compatible with the fact that the tachycardia rate was just above the VT detection rate, which is very commonly seen during tachycardia, sinus tachycardia. And as soon as the rate exceeds the VT detection limit, sinus rate, if it becomes higher due to any reason, this episode can be detected. And the device was actually diagnosing it as SVT for a very, very long time. And these are the continuous strips where the device thinks that this is SVT. But here, for some reason, the device changes diagnosis to VT and then delivered ATP therapy. Here you see the ATP is being delivered, and then delivery of ATP actually accelerated the VT into fibrillation zone. And now you see clear-cut AV dissociation where the sinus tachycardia is going on in the upper panel, upper channel, but you see that faster rate in the ventricular sense EGM, which falls into the VF zone. This was again appropriately detected and diagnosed by the device as VF. And since it was the redetection, ATP was not applied, and then first therapy was a high energy shock, which terminated the tachycardia. And interestingly, you see that once the VF terminated, the sinus tachycardia actually changed to atrial flutter. So interesting things happening here. So all the following facts regarding in the episodes are correct, except the device initially diagnosed the tachycardia as SVT and then changed the diagnosis to VT. That's absolutely correct. The device delivered therapy due to expiration of SVT timeout. It is incorrect. The device diagnosed this as VT. We'll see why. And then the ATP resulted in acceleration of rhythm to VF zone. That's again correct. And the shock terminated the VF but induced atrial flutter. Now, if you look at why the device changes diagnosis, is if you look at during this sinus tachycardia, you find that there are certain PVCs which are premature, and this resulted in change in the AV interval ratios. And so the AV association delta, which looks at the second largest and the second shortest AV interval as detected by the device, if it is falls above the cutoff, it indicates that there is no AV relationship, and it diagnoses this as VT. And this is the reason it diagnosed this episode as VT. And this is again the schema of SVT VT discrimination in dual chamber ICD. If it is a 1-to-1 relationship, V is equal to A rate branch, it looks at the AV interval delta. And if it is suggestive of no association between A and V, it diagnoses this as VT. Else, it looks at the other SVT discriminators like the morphology and the sudden onset, and then delivers therapy based on whether, if any, or if all has been programmed. So again, going back to the same rate branch flow diagram, why this episode was detected as VT. And this is the treatment summary of this episode. ATP was delivered, which accelerated to VF, and then a 30 joule shock was given to terminate the VF. And these are the SVT discrimination parameters which are used in the Abbott devices, and the nominal ones values are also given here. And if the tachycardia, if these parameters suggest more, then it is likely to diagnose it as VT and deliver therapy. If the value is less, then it is likely to withhold therapy. So I think I'll end with this because of lack of time, and thank you for your attention.
So very nice presentation, sir. All are very interesting cases. Despite so many algorithms and so many things coming into newer devices, inappropriate therapy still is a larger problem that looms around the device therapies. Sir, I would like to request Dr. Karthikeya Bhargava to remain in the panelist so that we can have a greater discussion. And next speaker I would like to introduce is Dr. Neeraj Yadav, one of the upcoming very popular electrophysiologists
Sir,
in our
just
country.
one.
So over to Dr. Neeraj.
Sir, instead of Dr. Neeraj, it will be Dr. Deba Pratha who will be presenting.
Oh, sorry. Okay. I would like to introduce my great friend, Dr. Deba Pratha, to present his cases.
Neeraj has some family issues, so I had to pitch in. So thanks for having me here.
Yeah.
And it's a privilege to present in such a prestigious forum with Dr. Karthikeya sir, Professor Ellen Mojan and Professor Friedman. So I'll share my screen and I have two cases. Just a moment. Sir, can you see my screen, sir?
Yeah, we can see your screen.
Okay. I'll start off. So coming to my first case, she's a 45-year-old lady with dilated cardiomyopathy, and she had documented monomorphic VT for which she received ICD 2 months back. It was a Medtronic ICD. Now she was doing well otherwise for last 2 months, and when now she presents with the audible alarm and 3 episodes of shock within last 2 days. So I'll first go to the alarm first. This is the audible alarm. So, dear Velu, is it audible? The alarm is audible?
Yeah, it's audible.
So, this is the alarm which the patient presented with. The first question is, although it is not a EGM, the first question is, what does this alarm indicate? So, these are the 5 options. If we can have the voting and let me know the results. So, is it about abnormal lead impedance? Is it about lead integrity alert? Is it of battery depletion? Or is it about high threshold or recurrent shock? Any voting has come? Actually, there are multiple options are correct in this.
Yeah, so it is option 2 and option 5 that people have selected for.
Okay. So the right answer is actually 1, 2, and 3. So in Medtronic devices, if you have abnormal lead impedance that is out of range, this kind of alarm comes. Second is, even if the abnormal lead impedance is not out of range, but there is a lead integrity issue, there are 3 criteria in that. We might discuss if time permits. So if there are non-physiological intervals being detected, or the lead impedance has changed significantly, but it is not out of range, still the lead integrity issue might alert similarly present with this sound, or if there is a battery depletion, the similar sound can come. High threshold and recurrent shock does not usually give rise to this kind of alarm. In this case, which was implanted just 2 months back, we can essentially rule out a battery depletion. So possibly these two are the most likely culprit, which will go and interrogate the device and it will tell us. So when we interrogated the device, there are multiple episodes of ventricular fibrillation being documented. And this is one of the electrogram. I will go to the options first, then I'll come back to this electrogram. So these are the two, here what we see here, this is one of the episode, and there is a shock which has been delivered, high energy shock, around 36 joules shock being delivered here. The upper one is the near field electrogram, and this is CAN2 coil, that is the far field discriminatory electrogram. Similarly, there are another episode where this kind of ventricular fibrillation has been documented. One of the shock has been, if you see aborted, it is written, the aborted one of the therapy. And there is again another detection of ventricular fibrillation. So the question is about the shock. Is it an appropriate shock? Is it an inappropriate shock? Or is it an unnecessary shock? I'll go back to the shock delivery and I'll come back to, now we can start the polling actually. Then we can discuss about it. So is it appropriate? Option A. Is it inappropriate? Option B. Or is it unnecessary?
So 67% have voted for inappropriate and 33 for unnecessary.
Correct. So here what we see in the near field electrogram, there is a lot of noise which can often sometimes be seen in ventricular fibrillation also, although they doesn't look like this. We will show how the ventricular fibrillation looks like. But if you look at the far field unipolar electrogram, we can see clear QRS complexes at regular intervals. So this is certainly some oversensing which has been reflected into the marker channel, and this reflection of oversensing is predominantly from the near field tip to ring electrogram. The far field shows most likely a sinus rhythm with a regular QRS complexes. So it was an inappropriate therapy. Now, what could be the reason for this oversensing? Because as I showed you that this was oversensing, the far field usually shows a clear cut QRS complexes at regular intervals, but the near field shows this noise kind of electrogram which has been reflected in the marker channel. Now the question is, can we predict from the electrogram what could be the possible reasons for oversensing? I have given 5 options. So we can have more than one option correct as well. Let us carefully look at it. So can it be lead fracture? I haven't told you about the impedances and everything. We'll come to that. So from the electrogram itself, can we comment this is a lead fracture, or it is a loose set screw, or it is a EMI, or some kind of myopotential, either pectoral or diaphragmatic? I'll go back to the electrogram again and I'll come back once the polling is over.
It's for option 3 EMI.
Okay, so EMI obviously is one of the option when you have this kind of noise, but generally EMI affects both the near field as well as far field simultaneously and almost equally. What we see here is more of near field electrogram being affected much higher than the far field electrogram. This is one point. Secondly, if you look here in the electrogram, this QRS complex, which is very well visible here with a good amplitude, has not even been reflected. So that means these are most likely oversensing, but along with that, these QRS complex, this is being reflected and sensed. These QRS complexes are being undersensed. Even this pacing spike, which is a V pacing, we feel that this is not captured. So along with the oversensing, there is something more into this. So if we go back to one by one of the options, so in lead fracture, generally this kind of uniform nature of electrogram and noise is not visible. Generally lead fracture and loose set screw, they have a make and break kind of signal. Usually you have sometimes a high signal with a saturation with cutting of the electrogram. Almost whole of your printing screen will be having that. Both this lead fracture and loose set screw also will have some kind of impedance changes, although I haven't not given the data. EMI, as I discussed, can have affection into the far field as well as near field. Generally, nowadays we have near field sensing. That means the sensing of the ICD is from the tip to ring. So if EMI is from the external surface, they are often not being reflected into the marker channel. So hence they generally do not lead to a oversensing and shock. They can be reflected in the far field channel more than the near field channel. Coming to the pectoral myopotential and diaphragmatic myopotential, both of them can lead to some kind of noise here. Pectoral myopotentials are again more well seen in the far field electrogram because the can is near the pectoral muscle, whereas the diaphragmatic myopotential is one of the differential which is more reflected in the near field electrogram, provided your lead is having lead is not inside the heart. So from this, although it is from this only electrogram, we cannot be commenting that it is out of the heart. But what we felt that there is a sensing issue which is the lead is not sensing, some of the under sensing is there, over sensing of the noise is there, and some lead was not capturing also. So all sort of things reflected that there was a lead issue. However, the lead impedances were normal. All the lead impedances, sensing, pacing as well, high voltage impedances were normal. And on the X-ray, what we found was the lead was almost out of the heart. So this explained all our features, that the near field electrogram having noises, which was even cyclical. So these noises were sometimes varying. This happens with the variation of the respiration. So all these things suggested that the lead has perforated out of the heart. So what we had to do, we had to reposition the lead in the hybrid OR. So this is the impedances. What we being shown here is almost normal, although there is slight fluctuation. And this is the defib impedances. But what we find here, the threshold has been erratic. Just immediately a few weeks after the implant, the threshold has been very erratic and high thresholds, and the R wave amplitude has come down. So all these features suggested that the lead is not inside the heart and it was pulled out. So it was a ICD lead perforation to conclude, and the oversensing was because of the diaphragmatic myopotential. There was inappropriate shock, and the alarm was because of the lead integrity issue, and lead revision was done in the hybrid OR. Fortunately, there was no pericardial effusion. So we'll go to the next case. It is a 45-year-old lady with Abbott ICD for a secondary prevention of hypertrophic cardiomyopathy and syncope. She was doing well for last 2 years, and now she comes with 3 episodes of ICD shock. When we interrogated the device, it showed there was multiple episodes of ventricular fibrillation, but all of the episodes started with a SVT, and finally the SVT degenerated into ventricular fibrillation. I'll be showing the EGMs from the subsequent slide. There are many other SVT episodes also which were self-terminating. So this is one of the VF episode which started like a SVT. So why I'm telling, because it is started like a SVT, because if you see here, the first beat is here. This is the first beam. The upper panel, channel is the atrial sense electrogram. The middle channel is the ventricular bipolar electrogram, and this is the discrimination electrogram. So what we see here, a tachycardia starts with almost like a 1:1 AV ratio, and the same tachycardia continues. Now the question is this a sinus tachycardia? Is this some kind of a pathological SVT like AVNRT, AVRT, or atrial tachycardia, or it is a VT? So these are the 3 options. I'll go back to the tachycardia. So this is the continued tachycardia. If I go back, this was the beginning of the tachycardia. Our options are sinus tachycardia. Second option is some kind of pathological SVT, or third option, it can be VT as well. If we can open up the panel, please. Is the voting on?
Yes, sir. It's for SVT, AV, and RT.
Okay. So it is correct that it looks like the tachycardia has started suddenly, and there is a premature atrial complex which has initiated the tachycardia. More importantly, if you look at the far field electrogram and the math score, after these few beats, the math score looks like 97% in this slide. And when the tachycardia continues, the initial part, if you look at it, all the tachycardia beats had a matching score template match of 96 to 98%. So this looks like a supraventricular tachycardia with 1:1 conduction till now. However, on the second half of the screen, if you look at it, many of the math score are less than 70%. And in fact, visually, eyeballing also, you can see the QRS has little become wider, and maybe because of the rate-related aberrancy. So the answer was a second option. It was a pathological SVT. Now the question is, with this background of hypertrophic cardiomyopathy, which is the most likely SVT, the way of onset what we have noted? The question answers are options are atrial tachycardia, AVNRT, and AVRT. Can you open the polling?
Yes, sir.
Please.
It's for option A, 80.
Tachycardia. So this is exactly what I also thought. Having hypertrophic cardiomyopathy in the background and the atrial premature beat inducing a 1:1 tachycardia with slight wobble, I thought it is atrial tachycardia. And in hypertrophic cardiomyopathy, sometimes we have multifocal atrial tachycardia. It may not be a single focus. So I initially did not think about ablation, and I offered them a medical management and started her on amiodarone. But after within next 2-3 weeks, she presented with another couple of episodes of shocks, and when we had to consider ablation. We'll come to that part later. Now, if we look at it, although we thought atrial tachycardia is the most likely diagnosis, as I told that even after starting amiodarone, she had multiple episodes of similar SVT degenerating into VF. This is one such slide. So there is a SVT going on. Suddenly there is a VT or VF started. I think this is the first beat of the VT, and it has possibly terminated the SVT and the VF goes on. Now the question is this episode a true VF, or it is atrial fibrillation or noise? It may be a very basic question, but for the youngsters who are in the audience. So is it a VF, atrial fibrillation or noise? I'll go back to the slide. So first option is VF, second is AF, or third is noise.
So people have voted for option, it's 50-50 for VF and AF.
Okay. So this is upper channel. If you look at it, the upper channel is atrial sense electrogram. We can see clear organized electrogram in the atrial channel. So this is definitely not atrial fibrillation. Rather, what you see here, this is the far field electrogram, which looks like a typical torsades kind of polymorphic VT kind of morphology. So this was a true ventricular fibrillation, and the answer is right answer is 1. And for the true VF, she received a timely therapy. And the same thing happened even after starting amiodarone. So this was a SVT every time inducing a ventricular fibrillation. And when we started amiodarone, and even after that, she came back. I discussed with 2 of my friends in CMC Vellore, Dr. John and Dr. Sirish. So they suggested few things, and we looked back into the electrograms, which I have already shared. So this is the onset. When we looked at it, so this is the PAC which started off, and the way it started off, we told that in the background of hypertrophic cardiomyopathy, there was the most probable substrate of tachycardia is atrial tachycardia. But when you looked at it, it looked like that there is after the PAC, there is a PR prolongation. So when you have, and every time this was happening, when you have a PAC, if you compare with the previous AV interval, this AV interval is longer at the onset of the tachycardia. So what do you think is the most likely tachycardia for this kind of onset? Is it atrial tachycardia, or is it a AV node dependent tachycardia like AVNRT, AVRT, or it is a JT? Can you open up the polling, please?
It's for option 2, AVNRT, AVRT.
Correct. Can you let me know how many minutes is left for my presentation so that I can accordingly wrap up?
Just a minute, sir.
1 minute is
1
left?
minute. Yeah.
Oh, fine. So I'll try to wrap up. So it is correct that it was thought of AVNRT versus AVRT because at the onset of the tachycardia, there was a PR prolongation. So in addition to that, there are a few other things. So what we noted that there was some wobble, and in the wobble, the VV cycle length drove the AA cycle length. So this, which SVT is ruled out when you have a VV cycle length, VV as the driver of AV. So which is ruled out? Which of the SVT is ruled out?
So it's option A, 80.
Correct. So in atrial tachycardia, the AA is generally the driver of the VV, whereas the AVNRT, AVRT, and also VT. In this case, we are not thinking about VT. So in this case, it is AVNRT versus AVRT, the DD. atrial tachycardia is essentially ruled out. Then we found that as soon as there is a onset of VF, the tachycardia on the atrial channel broke. So we felt that when a SVT terminates with a PVC or a VT, it is generally a AVRT. That was the most likely diagnosis. So I'm skipping the polling here. So it is most likely from this EGM, we thought the patient can have a AVRT. And a similar kind of termination was there in another episode. This was another episode self-terminating when two spontaneous PVC terminated the tachycardia. So all these things prompted us to consider ablation. This is one slide which is also useful for deciphering the mechanism of tachycardia. When you have a ATP and if the tachycardia would have continued, we could have even measured a PPI minus TCL. In this case, the ATP actually terminated the SVT. But what was interestingly noted that the pacing cycle of the ATP was immediately achieved on the atrial cycle. So it seems that either the tachycardia terminated immediately or it got entrained immediately in the second beat itself. So this is again another feature that the patient might have a AVRT rather than AVNRT or atrial tachycardia. So all these prompted us that we should go ahead for a EP study. This is a ECG of the patient where we also found that there is a short delta and possibly the patient may have a pathway. And she was offered a EP study. During V pacing, the atrial activation was eccentric and there was a very easily inducible AVRT via left lateral accessory pathway. This was the onset of the tachycardia with atrial extra stimuli. We can see the eccentric conduction during the SVT. And during V pacing, the eccentric conduction was abolished and the patient underwent a successful RF ablation. Interestingly, the patient also had a incidental fascicular ventricular accessory pathway, which is generally benign and not ablated. So I stop here. Thank you so much for the patient hearing.
Thank you, Dr. Debrath, for a wonderful case presentations. And now I invite Dr. Kenneth Ellenbogen from Virginia, Richmond, Virginia, a well-renowned cardiac electrophysiologist whose textbook we have actually learned since many, many years ago. We have been reading his books, and so we are privileged to have him here to present his talk on these interesting cardiac implantable device EGMs. Dr. Ellenbogen, please.
Thank you. That was an unusual case of tachycardia-induced tachycardia, really pretty impressive and makes you realize patients with hypertrophic cardiomyopathy can get to VF in very many different ways. So I've really enjoyed that last case. I'm going to present a couple of tracings here. I hope you'll enjoy, find also challenging. One, start off with a very simple case and then work our way towards a much more complicated case. The first case is sort of straightforward to get you warmed up. It's an 83-year-old man with a past medical history that includes ischemic cardiomyopathy and EF at 25%, left bundle branch block, and class 3 congestive heart failure. Undergoes CRT implant in 2014. And then this is the information we obtained from a remote interrogation. Now, I'm only not giving you all the information, just a limited amount of information, but here is how the BiV outputs are programmed, and this is how the VTVF is programmed. So those are device program parameters. And then these are the lead measurements, the diagnostic data. You can see there the patient is receiving BiV therapy, 100% RV pace, 100% LV pace. Had 3 episodes of non-sustained VT, had 1 ATR less than 1 minute. And these are all the relevant parameters from the device. And here's the presenting rhythm on remote follow-up. So the question is, and it's a simple one, what significant device information is noted from the presenting strip on the remote monitor. Appropriate device function, LV oversensing. Sorry for the abbreviations. It should be LV loss of capture and RV loss of capture. So I'll go back to the tracing. That's the question. And just, we should have people vote. Just a quick, straightforward question to get people's juices flowing. At least for us, it's fairly early in the morning.
So people have voted for option A, appropriate device function.
So that's the tracing. Give them about 5 seconds here. On A, B, C, D here. Okay, do you think that's enough time? I guess I'll just go ahead. Yeah. So focus your attention on this part of the strip. It's just an example of what's going on, and you can see a pacing artifact here, a pacing artifact here. You see the RV fairly close and the LVs away. So this, and you see LV pace and LV sense, indicating on the presenting rhythm strip, although the device thinks it's pacing the LV 100% of the time, the device is pacing the LV 100% of the time. The problem is the device is not capturing the LV 100% of the time. So just, that's how useful remote follow-up is in patients. So the second question is, well, what are you going to do? Increase RV output, increase LV output, increase LV protection period, decrease LV sensitivity, assess alternate LV pacing vectors. Again, on this one, there's more than one correct answer. We'll just go right over it. And the correct answer is either increase LV amplitude or try an alternate LV pacing vector. But remote follow-up makes an urgent need for the patient to come in. So this is a pacemaker question. 69-year-old, long PR interval, undergoes implantation of a dual chamber Abbott pacemaker or St. Jude, whatever, and is having episodes of AFib. Okay, this is the presenting rhythm. And then there'll be a question. The question is diagnosis atrial tachycardia, pacemaker-mediated tachycardia, repetitive non-reentrant VA desynchrony, or far-field R-wave oversensing. So what do you think is going on here?
So people have voted for our option 3.
Okay, RNRVAS.
Yeah, and 50% have voted for option 3, which is PMT.
And well, they got it wrong. The answer is option 3 is correct. And what you see here is the patient has a PVC here. The first day is in the patient's post-ventricular atrial refractory period. So we set up repeated AV conduction where the A falls into the PVARP due to functional non-capture. So A refractory, then A pace is in the relative refractory period of the atrium. So we set up repetitive episodes of ineffective atrial pacing and repeated VA conduction where the atrium is in the PVARP. And I'll talk a little bit more about that. We'll talk a little bit about the differences between pacemaker-mediated tachycardia and repetitive non-reentrant VA synchrony. It's an under-recognized cause of pacemaker-related arrhythmia, and the device often treats that, will often in some of these devices, will identify these episodes as episodes of atrial fibrillation. The difference between pacemaker-mediated tachycardia or endless loop tachycardia and repetitive non-reentrant VA dysynchrony or synchrony is that the retrograde P wave occurs within the PVARP, and in pacemaker-mediated tachycardia, it occurs outside the PVARP, okay? So here's an example of RNVAS, where the retrograde P wave occurs within the PVARP, okay? And so I'm gonna give you, so what else? It's promoted by a long PVARP. Long AV delays will promote this, where pacemaker-mediated tachycardia is promoted by a short PVARP because the P wave falls outside the PVARP. You can see PMT with P-synchronous ventricular pacing. You can see this with any of the AV sequential pacing modes. And there are really no algorithms that are very effective at preventing or identifying these events. And there are no algorithms that are effective at terminating RN-RVAS, as opposed to the multiple algorithms, virtually every manufacturer's algorithms to terminate ELT. So these are the things that will can be prevented. These are the things, these are the programming maneuvers that one can do to prevent RN-RVAS. You can shorten the PVARP, although obviously on the other hand, this increases the risk of PMT. You can shorten the AV delay, you can reduce the lower rate limit. So I'm going to present to you another interesting case. This is a 69-year-old woman who presented with fatigue and palpitations. She had incessant tachycardia, and basically in 2017, she was brought to the EP lab. She had typical AV NRT with a really big CS. We ablated that, and then she had atrial tachycardia coming from mid-CS. We tried to ablate that from the left atrium, but ultimately ablated that from her mid-CS. That's February 2017. She comes back a year later with heart block, Mobitz type 2 AV block, about a year later, and we put a conduction system pacemaker in. And she was on a low dose of flecainide and metoprolol. She had some PAF, and her EF is normal, her valves are normal, and chamber size is normal. So she comes in, she's complaining for weeks that she has palpitations, but the pacemaker interrogation shows nothing, She comes in, and this is her presenting EKG. The differential diagnosis here is atrial tachycardia, AV node reentry with lower common pathway block. And I was really concerned that either she has an atrial tachycardia and is tracking it, or maybe she developed AV NRT again with lower common pathway block. So what are you going to do to figure out what's going on? There's no audience response here. So what are you going to do to figure out what's going on? And I sort of felt these episodes occur 20, 30% of the time and makes her feel breathless. So let's figure out what's going on. So brought it to the EP lab. So this is atrial tracking with non-selective his bundle pacing. You can see how narrow the QRS is. And you can see in V4, V5, V6, there's almost no isoelectric interval between the stimulus and the pace QRS. So non-selective his bundle pacing, QRS is about 100, 110, 120 milliseconds. But these episodes occur abruptly and they occur frequently. Heart rate's 105 beats a minute. And here's the tachycardia initiation and tachycardia termination. So you see, again, you see undersensing with apacing in the relative refractory period of the atrium. So that's tachycardia initiation. And then you see unsensed P wave and tachycardia termination here. So here's her underlying rhythm. Her underlying rhythm is junctional escape. So when you inhibit the pacemaker, she has a junctional escape of about 50 beats a minute. Sorry, 37 beats a minute. Her HV is 46. Here's dual chamber pacing at baseline. Pacing artifact, there's some intra-atrial conduction delay. and a relatively narrow QRS. So that's her presenting rhythm when she's not in tachycardia. Stim to LA is about 190 milliseconds. So you can say because of intraatrial conduction delay, she has actually left-sided AV dysynchrony. And then we paced her, and she had antegrade AV block at all cycle lengths on isopaternolol. So she has heart block. So this is a pacemaker mediated tachycardia of some type, not necessarily PMT. This tachycardia that she has incessantly is a pacemaker mediated tachycardia. But she has phenomenal retrograde conduction, 1-to-1 retrograde conduction to 460 milliseconds. And then at 450 milliseconds, she develops 2-to-1 VA block with a long VA conduction time. Her VA interval is actually 400 milliseconds prior to block. Here's the initiation of tachycardia. So this is the initiation of tachycardia. So what do people think this is? What kind of tachycardia is this? This happens incessantly to the patient, and we capture initiation of tachycardia here. Spontaneous in the EP lab. I'm going to share with you what it is. Here's a tachycardia cycle length, 596 milliseconds. And I'm sorry it's gained down in the HRA, but you can see clearly there's a 1-to-1 retrograde VA here. And that's the VA time. And that's the AV time. What diagnostic maneuver would you do next? We did ventricular pacing or VVI pacing, and it terminates the tachycardia immediately with the retrograde A. What's the diagnosis? You have antegrade AV block. You have retrograde VA conduction with long VA conduction times. Incessant PMT at 105 to 110 beats a minute, below the PMT rate cutoff. How do we treat this? So that's the interesting part of this case. How would you treat this? Medications, increase the PVARP, program an anti-PMT algorithm, but program it to 100 beats a minute, or ablation. In the interest of time, I'll tell you what we did. We went ahead and mapped retrograde conduction. This is the ablation catheter. This is the location of the ablation catheter, His bundle catheter. Here's her right atrial lead. Here's her His bundle lead that does non-selective His bundle pacing. Atrial lead, this is LAO. His bundle lead, non-selective His bundle pacing, ablation. Earliest activation was above the CS os, posterior to the His lead. Location of the fast pathway. One burn, VA block. 8 seconds of RF tachycardia terminates with loss of retrograde conduction. Post-ablation AV sequential pacing with non-selective capture. Here's the actual QRS duration, 98 milliseconds. No retrograde conduction. So the teaching points, I think this is a great case. Retrograde conduction with antegrade block is possible. Facilitates PMT. So you can have retrograde conduction even though the patient has complete antegrade AV block. Slow retrograde conduction can allow for PMT. So the last case I presented was repetitive non-reentrant VA synchrony. This case is a PMT with long VA conduction and PMT below the upper rate cutoff. It will not be detected by any PMT algorithms, and His bundle pacing can capture the distal His even in patients with antegrade AV block. I hope you enjoyed that case. Thank you very much.
Thank you, Dr. Alan Mohan. That's a wonderful case. In fact, the last case was fascinating. And the way we have treated, I don't think we have ever heard about ablating retrograde VA conduction to treat any patient. And so this was fascinating. Now we have Dr. Paul Friedman from the Mayo Clinic, another renowned electrophysiologist, and he will be presenting his cases in ICD and CRTDs. Dr. Friedman, please.
Thank you. It's a pleasure to be here. Are my slides showing up okay?
Yes.
Perfect. So thank you very much for having me. And Ken, phenomenal case, really enjoyed that. And I'm struck by how many new troubleshooting options we now have with HIS bundle pacing, which has introduced some amazing physiologic findings and some fascinating troubleshooting challenges for sure. You know, reviewing cases, as Chuck Swerdlow once said, is like going to the zoo. You can look at a bunch of different animals, or you can stand in front of one cage, dig deep. And what I thought I would do is I have, depending on time, 2 different animals we can dig into. And we'll start with a few cases. And this one was sent by a friend, a 60-year-old man who received a dual chamber ICD for secondary prevention. So he had a cardiac arrest 3 years ago. He gets no device therapy. He's using an iPad and he comes in for a clinic evaluation. I'll show you the electrogram. He has a known atrial lead malfunction. And here's the tracing. And I will take your votes on this question first. And then I'm going to ask you another question about it. The first one is this person at risk for a shock from this tracing? And it's a yes or no. So hopefully the votes will come across quickly. I can't see voting yet. Have people voted?
Are we having the voting currently?
Yeah, it's on, sir.
Yeah. So what's the audience think of this?
Oh, here we go.
Yes,
okay.
sir.
Everyone says yes. Excellent. So this will be a great discussion. I'm going to show you one more vote. So keep those voting pads out. And the next question is, what are you going to do with this? And there's a huge range of options. Replace the lead, tell the patient to avoid EMI, reprogram the ICD, replace the pulse generator, start amiodarone, or if anyone has any other suggestions, I'd love them to unmute themselves or put in a comment and let us know. And I assume we're voting now, right? Okay, good. That's the previous one, it looks like. That was yes or no. This one should have 5 or 6 options for people to vote on.
Well, yeah, it's on, sir. Now the voting is on.
Oh, here we go. Perfect. If everyone can go ahead and submit the vote now, and it looks like.
Dr. Friedman, we have a small request actually. We need some 10-20 seconds to prepare the poll and get the answers. Will that be fine?
Yes, it is.
Yeah.
So once this one is, you mean for this particular question?
50% for avoid EMI and 50% for other.
Thank you. Okay.
Mobile network
So,
work ಆಗುನದ
so
mobile network
interesting
work
is,
ಆಗುನದ
so half the, I'm sorry, if someone
upload
can mute
எதுல upload
themselves,
பண்றீங்க
I'm having a hard time hearing myself. Thank you. So half the people said replace the lead, half the people said avoid EMI. I'm pleased to see that no one suggested, but these are obviously 2 very different approaches. One is surgery and one is patient advice. Clearly, no one selected amiodarone, and we all recognize that we have a local RV signal that's recorded between the tip and the ring, and that's where we're seeing this very fast, uncharacteristic signal. And then there is a surface equivalent, which would be a coil to a can. So you have 2 large conductors that are widely separated that tend to have more morphology information. And we see here normal rhythm continuing throughout, and there's a known atrial lead malfunction. Now, it's interesting that often we can get some information about the look of the signal in terms of what it is. And what I've put here is a potpourri of signals. I'm not going to do multiple choice, but I'll just walk through these and everyone should just think in your own mind. I'll point to the box. So what is this most likely? We have an atrial signal, a ventricular signal. We see noise on both of them, which starts and stops at the same time. And this is characteristic for electromagnetic interference that's coming from outside of the body. So we see it on two different signals. And this one down here, we see the same thing. A couple of observations. It's bigger on the far field than the near field signal. Remember, the far field is a bigger antenna, larger electrodes, farther apart, better antenna. It's bigger here. So both of these are recordings of EMI. Both of these have certain similar characteristics. It's intermittent. It episodically saturates the amplifier and has these very high frequency deflections. These would either be lead fracture or a loose set screw, whereas this is more characteristic of myopotential oversensing. So we learn a lot from looking at these, and as we'll show, the signal I showed is also very characteristic, but it's none of these. And then again, just to underscore, and this was from a paper actually that Chuck Swerdlow, Ken and I, and Sam Asirvatham did a number of years ago, just highlighting lead fracture. I think we're all familiar with saturated amplifier, not cyclical, non-physiologic short intervals. Well, the thing I showed you was a signal called MV chop. And what happens is in devices, and this is specific to one manufacturer that use the impedance between the can and the coil to measure minute ventilation, because as we recognize, when you breathe in, there's more air in the lungs and the impedance of this current goes up. This is used for minute ventilation, but if the resistance, if the impedance becomes too high, and here you can see impedance increasing over time, these signals that are transmitted by the device itself can be recorded. In pacemakers, it's associated with minute ventilation. Turning off minute ventilation turns off the signal. In defibrillators, it's associated with the respiratory rate trend diagnostics. Now, an important characteristic is that they're delivered every 50 hertz. And when you look at the signals, now because of blinking, you won't see exactly 50 hertz, but they'll essentially be multiples of 50. So one way to tell is it has this characteristic look, and you can see the actual physiologic signal through it. The other way is if you actually look at the intervals, they end pretty close to 50 all the time, telling you that it's that signal that the device is transmitting. And normally it's typically delivered between a right atrial ring and the can, or in this case, in others it'd be, but if that doesn't work, then it can switch to the RV and the can. And so there is no risk of shock. Why is that? Well, look at what happens to the signal. Notice when it comes off. It turns out that as soon as the VF episode is detected, the signal goes away. That's because by design, the device during the duration, while it's determining whether or not VF is there, will automatically turn off detection, other signals to avoid confounding detection. You'll get a lot of these, but you won't have a risk of shock. And then the answer, of course, is to reprogram the ICD, turn off respiratory rate diagnostics to prevent, and that will eliminate these events from happening. So save the patient a surgery. Now, what is all this? Now, many of you are likely familiar with it, so I didn't put in the multiple choice questions for this, but while we're still standing at this cage, I thought I would just very quickly review some of this. And you'll recall that this device uses a rhythm ID algorithm, and part of that using vector timing and correlation is a morphology score. This specific electrogram is correlated 99%, correlated 99%. The nominal is 94%. This particular one is 84%. Note we get the very rapid signal that leads to the episode detection. Then in the VF zone, there's a duration that's programmable. And then once the duration is met, it starts to give us information, and then the charge would start. But of course, at this point, the so-called arrhythmia has terminated. Here's another case. I will take your vote on this. I'm going to show you 2 slides before you actually vote. Here's the first one, big picture, and I'm going to zoom in on the interesting parts three options: observe, reprogram, replace lead. Here's a zoom in of it. Same case: observe, reprogram, or replace the lead. I'll go back, and you can start voting now. And we'll go ahead and take your votes. Observe, reprogram, or replace lead. Is the voting tool open?
Yes, sir, it's open.
Thank you. I guess people are just thinking about it. Here's the big picture. Okay. And what is the answer?
It's for 3, sir. So actually the audience is divided between all 3 options.
All 3 options. Okay, excellent.
Yeah,
So
and majority is for option 2, reprogram.
Okay. So that's what was particularly interesting about this case. And we're standing at this case for a long time to look at the nuance, because all of us look at this and go, boy, this signal does not look like a fracture. And this signal does not look like the sort of poor connection or myopotential oversensing. Now, there are 2 fundamental and very important differences between this case and the first one. The first question is this likely, is this likely coming from that transthoracic impedance? And the answer is yes. It ends in 50s. So the source of the signal is the same. But you'll remember in the previous one, we had it only on the rate detecting one, not on the shock signal. In this second case, it's on both of these. Now, this is, again, an ICD. And the other thing is, the astute observer will notice that the impedance is going up quite a bit. And that this sensor, this respiratory sensor was disabled by the signal artifact monitor event happened. And it's giving us these very big impedance numbers, greater than 3,000, greater than 2,000. Here's the key point from this one. When you see this noise on both the rate sensing and the far field shock lead, you have a lead fracture. The signal almost never shows up on the shock lead. For this signal to show up, you need to have some impedance increase, but the shock lead impedances are typically so much lower, 100 versus the hundreds. For this, you rarely see this. So if you see it on the shocking lead, you then know that there is a lead fracture present and this lead needs to be replaced. Second finding, of course, is the actual impedance numbers that are incredibly high. But again, it's just one piece of information and you can't necessarily say, oh, there's a lead fracture, but this greater than 3,000 strongly suggests it. And then this signal artifact monitor is a software approach that was implemented by the manufacturer that when it detects this signal or a high impedance, it then looks for a different vector or it'll automatically turn off the source of this noise. In this case, we get a very high impedance and it immediately switches off. Typically, you would see this kind of signal. So it suggests that it just saw the very high impedance and turned it off. The signature as well, for those of you who have seen this before, if you don't get at least like a second of this, and which is what happens when this is the only cause of the switch, suggests that the lead is having a very high impedance as opposed to signal that's causing the problem. This was actually a young person with the ARVC and the Naxos syndrome, and this sort of unique arrangement of a transvenous system placed epicardially, as our pediatric colleagues sometimes do. And we all know that these epicardial systems, because of the bends and unnatural positions of the leads and forces, are far more likely to replace it. So here it is, just to summarize. Signal detected on the shock lead should not happen unless there's a fracture and these very high impedances that we see. And I kind of talked about this already. Another similar but different case. You may be familiar with this one. I borrowed it from the literature, but I thought it was such a nice thematic continuation that I put it in there. This is a 46-year-old man, ejection fraction 10%, non-ischemic cardiomyopathy, an Inogen mini single chamber ICD on a Sprint Quattro secure lead, high remote impedance. Other parameters are stable. He comes to clinic and everything looks fine. Normal impedance, normal manipulation, normal chest X-ray, normal fluoroscopy. But we do the remote monitoring and we get this. Observe, assess surgically, replace lead, replace device. 4 options. I'll take your votes now.
Sir, it's for 75% for option 3 and 25% for option 1.
Okay, perfect. It just underscores how complex and sophisticated these devices have been. And it's really important to understand these. So just to recap, you see the patient and everything looks normal. Remote monitoring looks terribly abnormal. And there's one piece of information buried in all this that you should keep in your minds. And that is the device is made by Boston Scientific and the lead is made by Medtronic. Mixed manufacturers. And when you think about it, all leads have certain standards, IS1, IS4, DF4. So those are standards defining how they should be made. But when they're tested, the manufacturers only test their own leads in their own devices. They don't mix and match. And there are at least 2 mechanisms of intermittent high impedance in normally functioning systems. So if you ever have a system where the leads and the pulse generator are different, be very careful. Don't jump to surgery. Call the manufacturers, dig into it. Here's one mechanism. Lead device mechanical compatibility. This is from Chuck Love's group. And you'll notice that Medtronic uses this multi-beam design, whereas Boston and Abbott use this canted coil design. And what's thought is when the lead is secured in place, there are these small movements that always happen. And this can generate microparticles that can accumulate and oxidize and affect connections and impedance. Or the varying surface oxides due to these varying touch points may be the reason for it. Now, what's interesting is pacing might eliminate it, although less clear for this. The other one that's been described is dissimilar metal oxidation. If you have 2 different metals together, just by the chemistry of the metals, you can get a galvanic voltage. You can also get oxidation. And in this case, when you have a Medtronic lead in a St. Jude pulse generator, at least that's how it was reported, it may happen with others, you have the titanium set screw touching a stainless steel tip. You get oxidation and you get these high impedances reported. But here's what's fascinating. Because it's oxidation or presumed oxidation, when you pace, so when you see the patient in clinic, the impedance goes to normal. So another key point is if you pace, like when you're checking a threshold in clinic, which then eliminates the oxidation, and then you check the impedance, it'll normalize. The remote monitoring uses a very, very low current and voltage for testing. So it's more susceptible to these elevated oxidation-related impedances. And that's why you see them on the remote monitoring and much less so, if at all, on the in-clinic visits. So really a fascinating variation. The answer here is to observe. It's a normally functioning system. I have one more in this series of cages. Do I have time for one more case?
Yes, please go ahead.
Okay, all right. Here is, forgive the numbering. This is another one that a friend sent me, fascinating case. Called to see a patient 2 hours post-implant. I'll have a series of just short questions. Here is a surface telemetry, and please, we'll take a poll on this question. Is it oversensing, undersensing, crosstalk, or safety shock? Because you'll notice we do have an artifact here. And we'll take the votes now. I'm not sure why it says safety shock. And
so
it looks like
everyone voted for option 3, crosstalk.
Okay. So this is a defibrillator, and crosstalk, of course, is when you have atrial pacing that is sensed on the ventricular channel. So atrial pacing sensed on the ventricular channel prevents output. So everyone saw the P waves and didn't see QRS, so you thought crosstalk. But I just want to point out that this is P synchronous pacing. So intrinsic P waves, and then the device senses the P, paces the QRS. There's no atrial pacing here, so this cannot be crosstalk. Crosstalk requires A pace, oversense on the V, inhibit V pacing. Here we now have the device interrogation and a longer list. Here's the atrial channel. So A sense, A sense, A sense. And now this is A in a refractory, or actually a blanking period. And why is the A in the blanking period here? Well, because the V's are sensing a lot. So then it automatically calls this blank, right? And here's the actual A signal near field. Here's the V signal near field. Here's the shock. And then here you can see what's happening after the shock. I'll take your votes now on this one, and then I'll give you the answer and I'll be done. This is crosstalk, electromagnetic interference, loose set screw, air in the header, lead fracture, or MV chop. Do we have an answer yet? People still thinking about it. And I'll tell you, it's not A pacing. There's no atrial pacing going on here. These are blank senses. So as you're voting, remember what I said 2 minutes ago about crosstalk. You have to have A pacing. And there is no A pacing. So let's take the votes, and then I'll move forward. Do we have the voting yet? Or are people still thinking about it?
I think for the sake of time, Dr. Friedman, please go ahead and explain.
So
Sure,
it's option 3, sir, that has been voted maximum.
Option 3, loose set screw. Okay. So I'm going to go back a few slides. It's not a loose set screw, and just show you what a loose set screw looks like. A loose set screw would look exactly like, I'm sorry, this is a little slow, but I just want to make sure we're clear. A loose set screw looks like a lead fracture. It looks just like this. High frequency, intermittent, comes and goes, or like this. This is a loose set screw. And I wanted to jump to this just to show you how different it is than what we're looking at, which I'll now, as soon as my slides get back there. Okay. This is air in the header. Now, it's a really uncommon thing, which is why it's so confusing. And here's what happens. You have some damage to the seal plug. And what you can see here is an RV electrogram. And then all of these little things that really look like real signals, but notice how they're getting smaller, is what's happening when a droplet of air goes through here, and then you temporarily have a fluid connection in between the inside and the outside of the set screw. It allows conduction to happen, and you get this little signal. And you think, my God, how can this patient have 2 different rhythms at once? Well, they're not. These smaller ones are artifact caused by this. And you know it's this because it happens right after implant. You see it only on one channel, not, for example, on the far field one. Typically, it's the near field one because that's what leads to detection and charge. And again, here is the mechanism, and here's a reference of when it was, described some time ago. There have been a number of cases reported. Again, you see the similar sort of characteristic. Here is another one where you have, again, these sorts of signals. And typically, if you could just wait a few days, turn off detections, all the air will eventually come out. Or you can go in and you can open it and you can sort of put the screwdriver in and out and let all the air out and close it back up. So patience or an intervention will take care of it. And with that, I'll stop. I have a whole series of cases for another time. And I'll thank you for your attention and for the opportunity of sharing these cases with you.
Paul, that we also describe that, and we call it burping the generator, letting the air out. We call it burping the generator, burping the screws.
And then do you do that, Ken? Have you had any cases where you've operated, or do you typically wait a few days?
Unfortunately, I didn't know what it was the first time I saw it. And actually, the first time I saw it, it was with, happened to be with a Medtronic. So I brought the patient down, and I changed the generator, and then they said, "Oh, there's nothing wrong with the generator." Felt like an idiot.
It was far more common at one time with Boston when they switched to those orange colored seal plugs. They were really prone to it. You may remember that. And then they switched away from those, so it's no longer an issue. But it's good practice, as you pointed out, to just put the screwdriver in, pull it out, and put it back in before tightening the screws to minimize that happening.
Karthikeya, I would just want to come in here. We need to.
We're just closing it. Yeah, so wonderful cases, Dr. Friedman, Dr. Alan Bogan. It was great learning. Thank you all for making it happen. Once again, thanks a lot. And wonderful session today. Thank you.
Thanks very much.
Everyone stay healthy.
Thank you.
It's great to see everyone, even